Welcome everyone. I'm Dr. Lind, Podiatrist here at Stoughton Health. Today we're going to cover a couple of broad topics such as bunions, plantar fasciitis, and Achilles pain. Hit some of the broad features of them, signs and symptoms, some causes, and some treatment options that we have for them. So kind of who I am, born and raised here in Wisconsin in Shawano up near Green Bay, stayed local for my undergraduate degree at UW-Stevens Point. I then went down to Iowa for 4 years of podiatric school at Des Moines University, followed by a 3-year heavy surgical training at Ascension in Milwaukee, and kind of covering some of the Aurora facilities over there as well. So my philosophy, first and foremost, on patient care is that the patient comes first. You know, for lack of a better term, you rent time from myself and my staff when you come in for an appointment. So we like to make it feel as though, you know, all your needs are taken care of. So next up is listening. Patients like to tell us exactly what they have going on, how long it's been hurting, you know, any aggravating features, sort of what they've done. So listening really helps us develop that plan going forward. And it's a team effort. You know, I can give recommendations and I can perform surgery, but at the end of the day, when it comes to physical therapy and rehab and, you know, elevating the foot or, you know, following this protocol, the patient really is the one that's leading the ship there. So it is very much a team effort. And then again, personalized approach is what we love here at Stoughton. It's a smaller facility, so we really kind of focus in on exactly what patients have and what their needs are, and sort of tailor a treatment plan that follows what their best interests and needs are. So understanding the foot. I throw this up here kind of just to show you that it is a complex structure. It's 28 bones, 33 joints, 112 ligaments, and there's 21 intrinsic muscles that originate and do their action in the foot. And this doesn't include all the muscles of the leg that also attach and perform functions in the foot as well. So, you know, there's a lot going on in a small space. It's similar to, you know, the hand. It's sort of homogeneous to the hand. So again, we'll kind of hit some of the main, most common pathologies that we see here in clinic and kind of in the foot and ankle world. And then we'll go from there. We'll start with bunions. So what are bunions? Bunions is the prominence on the inside of the big toe joint. The big toe drifts over towards the second, and it's also called hallux valgus or hallux abductor valgus, HAV. Some signs and symptoms is irritation typically is the first sign that people get on that medial bump there. If you can see my cursor, it's, you know, you get this kind of redness and irritation as the foot widens and it starts rubbing on the shoes. You can get pain, numbness, and burning. And the reason why that occurs is because you have small nerves that run to the foot kind of over this corner, and they become irritated just as the skin does. The nerves lie right underneath and they get irritated, which causes some of that pain and numbness and burning. You can develop calluses on the inside of the foot, as you can see kind of in these more dramatic kind of sequence of the bunions worsening. You can kind of see that the big toe starts to turn, and you can get calluses kind of along the inside here and as well as over the bump itself. Difficulty fitting in shoes is another major concern that people have, as you can see down on the bottom. As you progress through, the foot sort of widens more and more to a point where getting into a regular shoe that you could buy off the shelf is actually quite difficult. And then pain to the second toe as well. And the reason for that is as this big toe drifts over, it starts to push that second toe up and out of the way. You'll notice here on the picture that there's, you know, callousing of that joint based on rubbing on the shoe. And you also get some ligamentous and capsule type injuries and pain to the bottom of the second toe because of this sort of dislocated state. So what causes bunions? So there's quite a few things. There's genetics. You know, there's certain conditions such as Down syndrome and ligamentous laxity type conditions such as Ehlers-Danlos syndrome. They're hereditary in a sense that you're more likely to develop bunions if family members had bunions or poor alignment. Poor fitting shoes, high heels, these tend to put your foot in a disadvantageous position. Flat feet tend to cause this as well. Based on the foot sort of falling out to the side, you start putting more pressure on the side of the big toe rather than underneath it. And then there's certain diseases, inflammatory diseases and rheumatoid arthritis, that cause damage to the capsule of the joint as well, which can weaken it and cause inflammation in there and destroy the cartilage, and then the toe starts to drift. So You've probably seen people with bunions, but realistically, what are we looking at when we order x-rays and how we determine how we're going to go about developing a treatment plan? So on the left here, you see a normal foot. And what we're looking at here is this line between the second metatarsal here and the first metatarsal here. And everybody, Kelly, can you confirm that you can see my cursor?
Yes.
Okay. Yeah. So less than 10 degrees between these two is considered normal. And then you can see over here, that same line, as this first metatarsal starts to bow out, you can see the soft tissue sort of shadow here and how big of a prominence there is. We also look at this, the line in consideration of the big toe and the first metatarsal here. So again, 10 degrees, whereas here, if you took a line straight out from the big toe, and you see that the big toe is drifted quite a bit towards the second there. So these are kind of the things that we're looking at, some of the main things. We also look at sesamoid position, these two little bones under here that act as pulleys. You can see over here, one's pretty much in the inner space and one's almost as far over as it can be while still being under the metatarsal. So these are kind of what we're looking at when it comes to general measurements of the bunion itself. So just kind of at a cursory view, what do we have for treatment options? Well, there's wider toe box shoes, based on the picture there. If you have something that comes to a pretty aggressive point, I'm thinking high heels, dress shoes, things of that nature, you tend to put a lot of pressure on the inside of that big toe, and it pushes the big toe over towards the second. There's some softer toe box or shoe covers, or something that's a little bit more mesh, or something that doesn't have a hard seam right overlying the bunion itself. If you do have dress shoes, you can get those, a cobbler can sort of mold that position to give you a little bit more space within a leather shoe. And then we have our different sort of offloading pads. So you have one that gives you a little bit of space if you have encroachment over the second. It also provides you this gel cover over the bunion itself to try to limit some irritation. Similar thing here, it's a little bit more of a slip over type dressing here, a pad. And this just has that silicone inside here. It doesn't give you any sort of relief if the big toe is really encroaching over on the second, but it's still an option for early bunions. Physical therapy may help strengthen the foot. So you may be able to do some exercises, or if you have, one of the other causes, if you had a flat foot that's causing your bunion, you may be able to do some physical therapy to strengthen the tendon to sort of reduce the amount of, stress going through there. I don't have it listed here, but orthotics, again, kind of depending on what condition you have that's leading to your bunion, you can get some relief from the orthotics, allowing your foot to be in a more rectus position. And then we have surgery. Really, when all of these fail, when you just have continued pain and it's really limiting your daily activities, that's when we really start to think about surgical options. And then what are we looking at again for surgery? So there's a lot of different ways to skin a cat. There's hundreds of ways to perform a bunionectomy. If you look up here, there's kind of the different incision styles that you'll tend to see with bunion procedures. And then, if you look down here, again, we're looking at first metatarsal, second metatarsal angle, and then the angle of how the big toe sits with the first metatarsal. Does it sit in line, or does it kind of cocked off to the side there? So you can see here, first metatarsal, second metatarsal, not a whole lot of space between them, and that big toe is nice and even with the first metatarsal. When it comes to surgery, there's really two main areas that are performed these days. And the first one would be known as a Lapidus procedure, which would be these two. And that is a fusion of the joint back here, your first tarsal metatarsal joint. And you can see that that's where your deformity sort of stems from. It's just based on the joint surface, it kind of worsens at that location. That's what these two are accomplishing here by fusing that big toe joint, the first tarsal metatarsal joint. Your other options here are known as an osteotomy, or a cut in the bone. And what they're doing is they're out further in the foot, and the idea is to make a cut and move the head of the bone over to effectively reduce the distance between the two bones. And then again, if you just drew a line through the head of the metatarsal, your big toe is again straight in line with it. This one here is sort of, I wouldn't say newer, it's been done since the 80s, but it's become much more utilized in today's age, and this is a true MIS, or percutaneous type bunionectomy. So this one here, even though it looks like it has the most amount of hardware is actually these 3 little small incisions here. And what you do is you make just a little small poke hole here, you put a burr in to make your cut, you shift the head of the bone over, and then these 2 little incisions are for your screws. And then the reason why people like this one is, again, because cosmetic reasons, with smaller incisions, as well as with a lot of times with these, you'll see here, you have to go in and shave some of the bump because you can only correct it so much. Whereas here, you can correct it quite a bit more, and then you don't have to shave down the bump, so you don't disrupt the normal capsule. And so you tend to get less swelling, less limitation and scarring of the joint of the big toe following the true MIS procedure. And then you'll notice on these 2, there's the small screws within the big toes. Those tend to be another, again, sort of wedge osteotomy or a wedge cut in the bone to allow the big toe to sort of be pulled off of the second toe, essentially. So this is, and you've probably seen marketing for it, this is a Lapiplasty system. It's the same as any other. A Lapiplasty is just a Lapidus, it's just the provided hardware. They have their own proprietary plating system. It's a dual plating, one on top, one on the side. This is the same procedure, just with different hardware. So if you've seen that marketed before. I would say the 2 that I performed, I do MIS procedures and then any number of Lapidus procedures. If somebody is, kind of dead set on having a Lapiplasty, I perform those as well. Otherwise, something similar to this would be my standard construct. And then moving into plantar fasciitis. So what is the plantar fascia? It's this thick fibrous band at the bottom of the foot that connects from your heel bone here all the way out to your toes. And it's broken into 3 segments. So you have a medial band, a central band, and a lateral band. And most people tend to get that pain sort of right in that medial to central. So again, it's the most common cause of heel pain. It's thought to be an initial inflammatory reaction followed by this chronic inflammation, which leads to just a chronic degeneration and disordered repair. So this is an ultrasound of the plantar fascia. So here's your heel bone, this kind of bright white line. And then these 2 lines here represent sort of the superficial and the deep aspect of your plantar fascia. And you can see here it's normal. It's asymptomatic. It's a normal thickness. You can kind of see all fibers, all these kind of white lines within these 2 spaces run parallel and together. Here's one of somebody who has plantar fascia pain. And again, here's your heel bone, this bright white line. And you can see how much thicker the plantar fascia has become. And it's just sort of disorganized. There's no real rhyme or reason with all this dark area between the 2 spaces. It's not like over here where you have these nice sort of linear lines. The fibers are all well aligned. Here it just becomes what's known as mucoid degeneration. It's just this chronic degeneration of the tendon. And then in very severe cases, that chronic degeneration over long term can actually lead to calcifications within the fascia itself. And you'll see, a very obvious plantar heel spur. We might chat on that later. I'm not sure if it's in another slide here, but again, this is sort of a consequence of just chronic inflammation at the site of the insertion. It's not directly related to pain in a sense that you don't walk on the spur. It just happens to be the site where the plantar fascia attaches. Chronic inflammation there can again lead to this calcification deposits. So signs and symptoms would be kind of a sharp stabbing pain at the heel or the arch of the foot, aching after long periods of standing or activity, swelling in the heel. This tends to be the first couple of steps in the morning or the first couple of steps after a long car ride when you really put weight down on that foot and sort of spread out that fascia when you step. Because the fascia acts as sort of a sling for the arch of the foot. So when you load the foot and you step on the foot, that fascia stretches and you sort of pull apart that disorganized degeneration, and that's what leads to your pain. So what are some causes? We haven't really identified any specific causes. There's been some correlations with high and low arch foot types, basically anything that adjusts the normal biomechanics of the foot and how you load the foot, how pliable versus how rigid the foot is. Equinus, which is just the medical term for a tight Achilles tendon or a tight gastroc muscle complex. Abnormal walking patterns. So again, if this would be sort of a low arch foot type, if you're sort of more abducted, where your foot is really kind of splaying out, pigeon-toed, people like to refer to it as, it can adjust how you're putting stress through that plantar fascia. Overuse, such as runners, long-distance runners, tend to have plantar fasciitis at some point during their careers. Obesity, and the more weight you carry, the more pressure that you're putting on those ligaments and those tendons, which can lead to that degeneration. And then standing on hard surfaces for long periods of time. Again, this is just thought to be a sort of a chronic degeneration, inflammation, and then there's really no support when you're standing on those kind of concrete hard surfaces. So what are some immediate treatment options? Well, first, there's activity modification. So if it's something that you notice that only comes up when you're doing long distance running, sometimes we recommend either reducing your mileage or taking some level of break from the activity that causes it. Stretching and massage, you can do this at home, as well as there's some very specific physical therapy options. This is first and foremost what we recommend for people, as it's shown the greatest and quickest sort of relief from pain. There's also inserts and night splints. This would be a night splint up here. And again, a lot of times this is plantar fasciitis is associated with that tight Achilles tendon, which is why a lot of this is looking at stretching and sort of like deep tissue massage. So this is something you would wear to bed at night. And when you bring your big toe up, you probably notice this, or if you do this at home, if you bend your big toe up, you'll feel on the bottom of your foot that fascia tighten. That's called the windlass mechanism, and it's a natural mechanism because when you normally step in walking and you take, it's called toe off, you have to sort of put your foot in a more rigid position to give yourself the power to step. So you would wear this at night to sort of keep that fascia activated and stretch your gastroc muscle, and you get what's known as tissue creep, which is just sort of a long-standing stretch of the tissue. There are some advanced therapies. This is a shockwave therapy. This isn't something that we currently offer at the hospital or I believe through the physical therapy department, but it is something that is available within the Madison area. A lot of sports medicine doctors and chiropractors and some physical therapy places will offer this. But basically it just uses high power or high energy waves to sort of break up that degeneration and allow your body to sort of reestablish the natural order of things. There's steroid injections, and then there's surgery. And this is this is one of the options. This is it's an endoscopic, meaning we use a little camera, 2 very small poke incisions, and you can see here is looking at the fascia. And then you just take a small knife and you cut about 1/3 to 50% of your medial and central bands. You don't want to cut the whole band because the plantar fascia does have a function in providing strength and support to the arch of the foot. So you can actually cause a destabilization of the arch if you cut the whole arch. Some people will get relief if they have a chronically inflamed one or a chronically degenerated one and they do something and they feel an immediate pain, they may have ruptured it. And people tend to actually heal quite well after that because it's essentially what we do in the procedure, in a surgical setting, just, naturally. So moving to Achilles pain, these are kind of the mainstays of Achilles pain. Tendinosis, tendinitis are kind of used in conjunction. A lot of things start as tendinitis and then eventually progress to a tendinosis. Osis meaning more degeneration, itis being more inflammation. We also have frank Achilles ruptures. You can get bursitis. There's 2 main locations in the back of the heel. You have this retrocalcaneal as well as a subcutaneous bursa. And these are just fluid sacs that the body creates when it's trying to offload a certain area. Sometimes people develop these in the feet, and it's just due to pressure. And then we have an insertional calcifications. Again, this is similar to if you saw on the other one for the plantar heel. And this again is just chronic inflammation, tendonitis at the insertion rather than in the mid-substance. And you get these calcifications, and some of these can become quite large. And as you can see, sometimes they break off, or sometimes you'll see them within the tendon themselves. And then back here is what's known as a Haglund's deformity. And again, if you kind of compare this setting to over here, you can see this one is much more of a sort of a light hill, essentially, if you will. And this one comes to much more of a point. And this is just, there's nothing that attaches here. It's just the natural development of the bone itself in the person. So some people just happen to develop a little bit more prominence here, but why this becomes an issue is because the Achilles attaches in the middle third of the back here. So as it comes up, it will rub and irritate on these more prominent type ones, and they can become an issue. So tendonitis itself is an acute inflammation of the tendon. This tends to be brought on by an overuse type setting. So somebody who maybe just plays sports on the weekends, so they're fairly sedentary during the week, rapid increase in activity, or if you're going on vacation and you're hiking a lot and you're going up and down hills or steps, you might notice some pain in the back of your leg, pain, swelling, and some stiffness. And eventually, just like with everything else, the tendonitis is, if it's left unchecked and not treated appropriately from the start, and you keep having these injuries or this irritation to the area, can lead to tendinosis, which is more of that degeneration and disordered repair of the tendon itself. Treatment options immediately would be, again, limiting activities that that aggravate the tendon. So if you're somebody who's kind of just a weekend warrior, only plays pickleball or tennis or whatever on a weekend, you might want to add some sport-specific training or workouts throughout the week, just to sort of condition yourself for those more intense activities. Immobilization or protected weight bearing is kind of, this is typically done in one of those big cam boots you've probably seen people walking around in. You can take NSAIDs and steroids initially when it's a tendonitis because these work to reduce inflammation. Physical therapy, there's an Alfredson protocol is the specific name of the one. It's an eccentric exercise, and this is typically reserved for more of the chronic, sort of 6 weeks or beyond, when you're out of that inflammatory phase and you're kind of in this disrupted repair stage. There's advanced therapies such as, shockwave is another one that's used for this. Some people have success with dry needling as well. And then night splinting, again, these tend to be caused by some, increased traction on the tendon itself, or that equinus that we talked about. So stretching the Achilles reduces some of the inflammation here, reduces the pull on the tendon or on the bone, in just the general kind of day-to-day life. And then surgery as well as a treatment when these really become quite long-standing and nothing's worked from a conservative standpoint. And again, this isn't a foreign body or a bullet. That is a calcification, just like we saw on the previous slides in the plantar fascia. It's a calcification that develops from this long-standing inflammation and degeneration of the tendon. Achilles ruptures, really these are broken down into partial or complete. You may feel a pop or hear a pop in the back of your leg. I was kicked in the back of the leg and nobody was around me is kind of a classic saying that a lot of patients have when they come in. And there's varying degrees of pain. Some people it's extremely painful. Some people it's not painful at all. It's just the immediate pop. You'll probably notice some weakness initially because this is the main plantar flexor of the foot. It really gives you your push-off power and your jumping power. You might notice some swelling, and specifically with the mid-substance ones, you might notice a little dell or a little divot where you can, if you run your finger over the back of the leg, you'll kind of drop down into a little spot. Diagnosing these, the complete tears are pretty easy to diagnose. Otherwise, we do have ultrasound and MRI. So, going straight to the MRI here, this black line along the back is the Achilles tendon. As you can see, it's pretty even thickness the entire way up. There's really no signal change. It's just a black line all the way through. Over here, you can see it's quite thick, and then you have this fluid. So white on this view particularly is fluid, and it's typically blood, plasma. It doesn't differentiate specifically, but you can see that there's not that nice kind of smooth black line of the Achilles tendon. You have this really disordered, disrupted tendon state. But typically these tend to be clinical. So, it's pretty obvious to see here, this is your non-affected side. This is somebody laying down on their stomach. You can see you have a natural tension to the foot. And all tendons have a natural sort of resting tension to them. It's what allows, there's no slack when you go to do something. It just happens. So there's tension on every tendon. And, this one you can see the nice, very well-defined Achilles tendon. Over here, it just looks like, a fat ankle, essentially. But you can see that they don't have tension in the leg anymore. So this isn't them trying to pull their foot up. This is them resting on both sides. And you can see the tension that you naturally have here where the foot is in a more plantar flex position, and you've completely lost that over here. Another option is this Thompson squeeze test. And laying down again, you can either have their leg up in the air or just flat down, but you squeeze the gastroc muscles. And because this is attached and there's tension on that tendon, when you squeeze the muscle, you'll see the foot plantar flex. When you have a disruption of the Achilles tendon, when you squeeze this gastroc muscle, since there isn't tension down here anymore, the foot doesn't do anything. And this would be a positive Thompson test. So I would say for the most part, in a setting with this and a positive Thompson test and a little dell, if you really push down in here, you would fall into the rupture. I don't often order MRIs for these very obvious ruptures. It doesn't really change management. Partial rupture treatment, these are rarely surgical. And typically we send these for physical therapy. And over here on the right is what's known as the Willits protocol. It's kind of the standard advanced rehab when it comes to Achilles ruptures in a non-operative setting or a partial rupture setting. So it's some period of non-weight bearing. And this is kind of that immediate 2 weeks afterwards, just to allow all that inflammation to calm down. And then you're given a boot with a heel lift, and the heel lift helps to shorten the tendon. If you think of your foot in a plantar flex position or, toes down, your Achilles is shortened. So we allow you to walk as long as you have, you're protected in a boot and you have this heel lift. And then you sort of move through your protocol, weaning off the heel lifts around the 6 to 8 week mark, weaning off the boot around that 8 to 12 week mark. And then again, this is in, alongside physical therapy. So complete rupture treatments, you can also follow the non-operative Willits protocol. So, how do you decide, and how do we decide? It really comes down to if you're active and younger, if you're playing sports, those types of things. We typically recommend surgical repair. The non-operative treatment does have a slightly higher risk of re-rupture because you're not putting the tendons end to end. You're sort of allowing the natural healing of the tendon to happen. You may have some weakness following the non-operative treatment. But studies have shown that satisfaction rates are actually pretty comparative, but you may not fully return to the level that you were at a sporting level or a high sporting level if you don't have surgery on the Achilles. So when it comes to surgical options, there's really the open or the minimally open, and then plus or minus anchors. So this right here would be more of an open setting. You can do these more minimally with certain percutaneous jig systems. But typically it's sewing up one side of the tendon, sewing up the other, and then you bring them together and sort of knot them together. And this is done with a non-absorbable suture. The disadvantages of the open procedure would obviously be a larger incision, so more healing time, more potential for infection, more potential for a dehiscence or a non-healing incision site, especially at the back of the leg. these can sometimes be very difficult and cause people problems from a healing standpoint. This would be more of a minimally open, so you can kind of see here they've drawn in the sutured incision site, where you use either a percutaneous or you just pull the tendon partially through the incision to sew it up. And then what you do is you use a tendon passer to go through the distal or the far aspect of the tendon, and grab these sutures, and then you use anchors through 2 small stab incisions in the back of the heel, and you anchor this tendon through this portion into the heel bone. So if you guys heard of Aaron Rodgers and his mid-substance speed bridge, that this is what he would have had here. And this has been around for close to a decade now. There are some disadvantages with this side. An advantage would be that it is stronger from a repair standpoint, but there hasn't been any difference in rupture or re-rupture rates between the two, or return to sporting between the two. But it does, like I say, it does have a sort of a bench or a study research higher level to failure. One of the problems I have seen with these is some people do get irritation from these 2 anchor sites. Anchors themselves can cause issues, but the small incisions, again, being directly on the back of the heel versus, up in the mid-substance portion of the Achilles tendon. So, normal shoes don't tend to hit the more open side over here, but they would hit these 2 anchor site incisions, which can scar in and be painful for people that we've seen in the past. But I perform both of these, again, very patient specific. I'm going to talk about Achilles insertional calcific tendinosis and Haglund's deformity kind of together. So this is really the pain at the back of the heel or leg. You get this kind of unsightly bump, and it becomes very irritated in shoe gear. You can have stiffness in the Achilles tendon. And these can be quite sensitive for people. So a Haglund's is congenital. So again, that's that more of the spike on the top of that heel bone versus the nice sort of smooth hill. It's congenital, meaning that's just how they naturally developed. There's nothing that attaches there that causes any issues. It's just the fact that they happen to have one develop that was more pointy than a normal person's, and it irritates the Achilles tendon. Achilles insertional calcific tendinosis is, again, that kind of big unsightly spike that's in the back, that spur at the back. And it's typically a consequence of just chronic traction and pull from a tight Achilles tendon or equinus. Spondyloarthropathies, such as ankylosing spondylitis, cause what's known as enthesitis, which is just an inflammation where tendons attach to bone. Patients with those spondyloarthropathies tend to develop more spurs throughout their body as well, very specifically as well in the foot and ankle. And symptoms may be worsened by having a rigid back shoes, or somebody who really likes to ski. That boot is a lot more rigid than, say, obviously an open back or a sandal, which doesn't have any back to it at all. So what are some treatment options? Typically, it's easier. Unfortunately, here in Wisconsin, we do have winters, so it's hard to be in open or soft back shoes most of the year. But those are options just to reduce some of the irritation on the bump itself. You can do offloading gel or sort of a horseshoe pad and sort of offload around the bump itself so that the shoe hits the pad or the gel instead of the actual bump itself. You can take anti-inflammatories. Again, people with ankylosing spondylitis they tend to be on some sort of anti-inflammatory or disease-modifying drug at a baseline. Physical therapy, again, for the equinus nature of the Achilles tendon, the tightness of the Achilles tendon. They don't have the range of motion at the ankle that they need to, which kind of causes this chronic traction. And then again, surgery. So what are some surgical options for Achilles insertional calcific tendinosis? Again, here you see the spike at the back. This person also has a Haglund's. They're not mutually exclusive. You can have both. So they would have had this done. The spur is shaved off, and then you sort of shave off the top. This can be done open, meaning that you have a large incision get access to it, and you have to remove the Achilles tendon because this middle third is where the Achilles tendon attaches. So you may be able to see this little bit of lucency in here. So if you take the tendon off to allow access to this and remove some of the degeneration of the tendon, then you have to reattach the tendon, which leads to significantly longer recovery time. And you're looking at probably 6 to 9 months before you're back to your kind of daily activities, and sort of 9 to 12 to return to sporting activities, if the Achilles tendon has to be detached and then reattached with the anchor, because you don't want to re-rupture that site. It's very bad. And an alternative, you can also, I should say, do these endoscopically, meaning that you go in here with a small camera and a burr and take them down. It's easier to do that on the Haglund's portion, much more difficult to do that with the spur itself, although it is possible because, like I said, the Achilles attaches here, but you can sort of disrupt some of the attachment of the Achilles to get to the spur. If you take too much of it, you do also have to anchor it back down, and again, it becomes a stability and a rehab sort of change from that. This is an alternative for a Haglund's and insertional. This is what they do. A lot of these in Europe. They're slowly becoming more and more common in the US, but it's what's known as a Zadig osteotomy. And what you do is you take this wedge out and you sort of close it down and put screws across this. And what this does is it changes your bump from here to here. So you sort of shorten the calcaneus, and it takes this bump away, and it takes some of the stress, because as this closes, it comes up just a little bit. So you take a little bit of tension off the tendon itself, and you move the bump. So you're taking out this wedge of the central portion of your heel, putting screws across it, and you're not actually addressing the insertion of the tendon itself, which again, this would lead to a quicker recovery than if you had to open and remove the tendon. So a lot of people are having good success with that as well. And again, this is something, this can be done open or MIS through a small poke hole with a burr, to again limit the incision site and limit the amount of pain that patients have after. And I know that was a lot to throw at you, but again, those are kind of just some general overviews, some common issues that we have, and sort of how we can go about it. Here's my information. If you're looking to come in and get more of a hands-on approach, or maybe some imaging to see if something's been bothering you, and kind of where we can go from there and what we can do about it.